Francisco, you talked about not reducing the dose of Cidofovir. So there's a common practice, I would say, I'm not sure I could say it's a common practice, but one option that people think about is don't use probenecid and use a lower dose of Cidofovir. And this is something we sometimes think about doing when we are trying to cut the costs of the drug. Is there any rationale for that?
Just, as you can see, the drug gets into the cells by passive concentration gradient. So if you don't generate the concentration gradient, you're not going to treat anything, right?
Okay.
So if you think about it, when you're doing the 1 milligram per kilogram without probenecid, what you're doing is dumping the Cidofovir in the urine because you're letting it be excreted in the tubule. So the only exception would be theoretically if you had a tubular adenovirus disease, you had adenovirus nephritis. But if that could give you a higher concentration, but if you're treating pneumonia, if you're treating encephalitis, if you're treating any non-kidney disease, you're just not doing anything, right? So, okay. And even for adenovirus nephritis, we prefer to use a 5 milligrams per kilogram and use the probenecid, because that way you get a systemic concentration of the drug. And again, these are viruses like you can isolate in multiple, for adenovirus, for example, and CMV, right? These are systemic diseases, right? For a lot of these patients. So, so I really, I know it's a lot of publications, but I just wanted to be very clear that if you're going to use it, use the full dose, otherwise don't use it.
Okay. So just one last question, because it came from the chat. What about when people have significant cytopenias or renal failure? How would you go about dosing? At what point would you say I would not use Cidofovir?
With cytopenias, there is no issue because, even though it was described as a side effect in the trials in the 80s with, in the 90s with in HIV patients, we don't see much neutropenia in the bone marrow transplant patients in which we use Cidofovir as a treatment for adenovirus or CMV. So the only question is renal failure, and that's a judgment call. So for CMV, we do have alternatives. As you said, you can even do third-party T cells. We have access to maribavir. We have letermovir. So thankfully, we have alternatives. For adenovirus, I would always use 5 milligrams per kilogram independent of the renal function because it's a lethal disease in our patients if we let it go. So it's a risk-benefit assessment.
Okay, thank you. Okay, Dharma, just to understand, can you just walk us through your CMV monitoring strategy post-transplantation, very broadly?
Yeah, so we do weekly PCRs now. We use the COVAS Roche platform.
Okay.
And basically, again, if we see virus loads are going up steadily, we start preemptive therapy. People at high risk now, we're using letermovir prophylaxis. The people with standard risk, who are not T-cell depleted on courts, we're still doing preemption. And then we also, after the 100 days, we do, if patients have acute GVHD, we continue surveillance. If patients don't have acute GVHD, then we go to a syndromatic approach, right? So people, if they come sick with anything, then we screen for CMV as part of the evaluation.
Okay, thank you. Thank you, Francisco. I'll just move to Dharma. Dharma, what would be your strategy for CMV monitoring?
Hi, good evening, and thanks, Marty. Is very nice talk. So what we do at our center, like those patients who are matched sibling donor transplant after engraftment, we monitor initially weekly and then put on fortnightly monitoring, and the copies number those who goes more than 1,000, then we start preemptive therapy. So those patients who are high risk, particularly haplo and mud, we are monitoring very closely weekly, and even we intervene if the copies number going more than 5,500, and then we start putting them as a preemptive therapy. So the rigorous monitoring for haplotransplant, the mud transplant, and patients who are on graft versus host disease. So before starting the immunosuppression, we send CMV for every patient. At least we are starting steroid-based therapy. So and we monitor up to 100 days very closely, and haplo and the mud up to 180 days. At least fortnightly, even they don't have the GVHD or additional immunosuppressive therapy.
Okay, thanks, Dharma. I think so. Everybody got that, both from Francisco and Dharma. Hey, Sharad, how are you? Just moving on to you. I just want to just to walk us through, Sharad, and I'm sure Francisco can pitch in. We all have these patients who have, we start ganciclovir for rising CMV copy numbers. 2 weeks down the line, the copy numbers are still high. We're still spiking fever. We can't find any other cause. And in India, we have limited options. How do you approach that problem?
Yeah, I think from our end, I mean, if I can just start on that, it is certainly a worry when you see the copies kind of not settling down, but you still kind of pursue with the full dose of ganciclovir. We just give it a little longer time frame, and we've seen some patients settle down just with continuing the same full dose of ganciclovir. We have issues of, I think, cytopenia and even the renal failure and renal toxicity come up, and sometimes that forces us to dose adjust. It's in that setting where sometimes when we are stuck and we have progression on that, we have to consider the alternative of either fosgard or Cidofovir, and that's when we bring this up.
So that's how do you choose, Sharad? How do you decide? Because this is always, there's never, 5 fellows in CMC, every fellow has a different opinion. So should we use fosgard? Should we use Cidofovir? We have limited options. So
yeah.
Any way that you go about it?
Yeah, no, I think there's no real algorithm here, Vikram, to be honest. I think a lot of it is finances, availability, which decides it. From a very practical perspective, that's what we do.
Right. Fosgard is expensive for us, Francisco. I mean, so that's often a challenge for us. But in an ideal world, with rising copy numbers and, essentially drug resistance to ganciclovir, what's your go-to drug, Francisco?
So I think, you have the kind of the first comment is the I'm blanking on his name, the group, the Emery and, the London group's kind of quick rule, which is you're allowed to, because the replication of CMV is on the way up, or is an exponential replication, even with effective therapy, in the center of GVHD, you expect a 1 log and a half increase in the first 2 weeks, right? So if you start at 1,000, you're allowed to go up to 15,000, 20,000 by 2 weeks, and that virus won't be resistant. You just have to sit tight, right? Okay, so that's an important thing.
So that's an important point. I want to stress, Francisco, I'm so sorry, because I think a lot of people don't realize this here. And there's often a tendency to jump and change drugs,
Exactly.
So that's an important point. So you're saying at 2 weeks, if you see rise with GVHD, don't react, just continue the drug.
Yeah, so basically, and it's a very good practical rule, right? So, and we're talking the logarithm phase, right? Let's say you start at 5,000, right? I don't know if you start everybody in-house or you just use the Valsite outpatient, but sometimes you start, even if you start Valsite as an outpatient, it may take a day or 2 or 3 for the patient to get the drug. You have to factor that in when the patient actually started taking the drug.
No, for us, it's instant. Here, that's not a problem,
Okay, anyway, so you start at 5,000, that patient can go to 50,000 in 2 weeks, and we don't change anything, right? So you tolerate up to 1 log, technically it's 1 log and a half, right? And actually, if you look at all the trials that we're doing now for resistant CMV, they say, no, you don't drop by a log in 2 weeks, right? So it's only in week 3 that you start being concerned with resistance, right?
So day 21. Day 21, if it's not coming down, you're concerned.
Exactly. That's when we do the switch.
Okay.
Or if you have clinical disease, right? Or if you go beyond the 1 log, right? That 5,000 patient is 100,000 on week 2. It's okay. This is too much. It's 2 log increase.
Got it. And when you go for switch, what's your switch?
So we go to fosgard. And what we do that, again, is not clear in the books is, remember that antivirals work not by peaking, as opposed to Cidofovir, that you need the peak to get into the cells. Fosgard gets into the cells very easily. So it's more like a penicillin. You just want to stay above the IC90, right?
Okay.
Okay. And then basically what we do is we always start with 60 milligrams per kilogram every 8 hours. We never do, we stopped doing the
90
12 hours probably 12, 15 years ago, because that's where we used to see a lot of renal failure.
Just say that again, Francisco. You stopped doing what?
The 90 milligrams per kilogram twice a day.
So you stopped doing that. Okay.
We don't do that up front.
Okay.
We always start with 60 every 8 hours.
Okay.
Then that makes sure that we don't get peak levels. We infuse it over 2 hours.
Okay.
1.5, 2 hours. So you don't get the peak levels, because that's what causes the tubular injury in fosgard. Okay. And then with that, we are able to control the infection without minimizing the risk of renal dysfunction. Right. So a rate of renal dysfunction with that approach is probably 20% if patients have normal renal function at baseline.
Okay.
Okay.
And what's the role of Cidofovir? What's the role of Cidofovir then?
So as I mentioned, for Cidofovir, we use it on the way down. Let's say somebody you have control with ganciclovir or valganciclovir, but then counts are very low. The patient clears, but let's say somebody with grade 3 GVHD, or somebody who had a cord or just had a haplo and got ATG, or so he's going to reactivate again. Okay. So before letermovir, it was very common to put those patients on Cidofovir for secondary prophylaxis.
Okay.
Because you could give it in the clinic when they come to clinic, right? So use it as a tail end. Somebody's 200-300 copies. It's already on the way down. We would use it in that sense.
Sure.
Knowing that you're going to have a 20-30% chance of the virus breaking through.
Okay. Thanks. Okay. We'll go to Dr. Ganesh. I hope he's on the. He's there. Of course. Hi, Ganesh.
Hi,
Ganesh, I'm just trying to understand in your haplo program, how much of BK virus problems do you have, and how do you approach it in terms of management?
As you have enumerated in your talks, BK virus related hemorrhagic cystitis or BK virus reactivation, in fact, is more common. But BK virus hemorrhagic cystitis manifesting clinically, grade 1 to 3, is also somewhere in the range of 15 to 20% in haplotransplant program. So essentially not having the effective antivirals across our management is mostly supportive, bladder irrigation, GCSF bladder irrigation, simple saline bladder irrigation, fluoroquinolones, and supportive care. This is all tranexamic acid, sometimes bladder irrigation when there is grade 2, grade 3 hemorrhagic cystitis. So it's essentially supportive care. And in just one of the patients, Fanconi's anemia post-haplo, having a grade 3, grade 4 hemorrhagic cystitis refractory to the persistent severe hemorrhagic cystitis, symptomatic patient was literally screaming, used to scream all through. So that we use Cidofovir, but I'm not sure how effective it was. My personal feeling is it just took 3 months and it resolved on its own, continued supportive care.
Okay. Thanks. I'm just going to move it back to Francisco. Francisco, what do you think is the role of quinolones in BK virus, either preemptive or as therapy?
I mean, it's like hydroxychloroquine for COVID. We have more and more stories showing that it doesn't work, but people keep using it.
Yeah,
right? So,
we use it. I can tell you we use it because we're often pushed to a corner. So we use quinolones, we use Cidofovir. We all know that, they probably recover on their own. So you don't feel there's any role?
There's placebo-controlled trials, both for prevention and for treatment or preemptive therapy, both in bone marrow transplants and in kidney transplants that show no more side effects. You get more tendonitis, tendon rupture, C. diff. So really, there are multiple trials, probably 4 or 5 now. Actually, one of my research assistants is putting together kind of a summary of all the randomized trials showing that both in the prophylactic setting and in the preemptive therapy setting, and the treatment, there is no benefit, right? So
Okay.
one of these things that, somebody went off the handle, and then, people keep doing that. So I think it is a major concern. We're motivated enough that we're doing a natural history study,
Okay.
with our group to understand the disease, because if you think about it, we don't even have a autopsy or pathology study of BK in bone marrow transplants there, because the kidneys get biopsy. We understand kidney disease in kidney transplant patients, but we don't really even understand what's happening at the pathologic level for BK. So it's a big gap, it's a big knowledge gap. And I think now with better treatments for CMV and prophylaxis for CMV, it's become the most obvious, viral disease in transplantation. But I think we have to be humble enough to say, we need to understand this better. They're gonna, and I think once we understand the disease and the natural history better, there's only one paper that's mostly in kids that came out early this year or late last year from the group in Philadelphia about the natural history of BK in children, but because it was done by kidney doctors, it focuses on the kidney, doesn't focus on the bladder or the hemorrhagic cystitis. So we hope that in the studies that we're doing, we're really trying to understand the symptoms. We're creating symptom scores, quality of life, to understand what's the morbidity of the disease, kind of so we can go on and then develop treatments. People are looking into T cells, third-party T cells. People are looking into monoclonal antibodies, but we need to move beyond the quinolones and Cidofovir for this one.
Sir, Vikram sir, can I also ask?
No, absolutely. Please feel free to ask.
Yeah, sir, to Professor Francisco. So we use a lot of leflunomide as a kind of not scientifically proven, but as a prophylaxis, particularly in haploidentical transplant for BK virus hemorrhagic cystitis, as well as an anti-inflammatory agent, just like we use for patients with chronic GVHD, HCQS. So what role this leflunomide has in BK virus hemorrhagic cystitis? And also the second point was, there is some literature coming up mostly from Professor Mathews' group that the post-transplant cyclophosphamide, rather than being given on day 3, day 4, if we space it on day 3 and day 5 and give a gap of 1 day, so does it decrease the incidence of the PTCY related hemorrhagic cystitis in the various alternative donor transplant setting?
Yeah, so I think one thing that I think we need to clarify is that my sense is that the incidence of BK disease in haplos is different if you use a myeloablative regimen than a reduced intensity regimen. So what we're seeing is that most of the severe diseases in myeloablative strategies. Second, I think leflunomide, I think it's like the zinc, or I think it's probably an anti-inflammatory. So in that sense, it's decreasing the symptoms, but I don't think it has any impacts on the virus itself. And I would propose to you guys, you guys could do that, a randomized placebo-controlled trial of leflunomide, but my sense is that it doesn't help the virology. It may help the symptoms, but it's kind of an expensive and toxic therapy. You do have a fair amount of liver toxicity and cytopenias, so which is something you don't like in haplos, especially at the beginning. So it'd be a very hard sell, at least for me and from people in my team here at the Fiber, to do prophylactic leflunomide in haplos that may have a hard time with counts to begin with, and a lot of CMV early on.
Okay. Thank you. Sorry, please go ahead.
No, you said that I don't think it helps, and some people seem to improve faster, but I wonder if because it's an anti-inflammatory, right? Like we use it in rheumatology,
right.
So
right.
Maybe that's what we're seeing a clinical effect in some patients, but my sense is it doesn't help that much, and you have to deal with the toxicities, which are not not problematic in the sense of transplantation, because liver abnormalities and log counts is something you don't like to have in early bone marrow transplantation.
Sure. Okay, we go to Dr. Mamta Manglani. Thank you, ma'am, for being here. This is, can you tell us your challenges with CMV in thalassemia in a setup that you're handling, with how difficult is it to monitor and intervene?
So basically, we are also monitoring in match sibling very sparingly, as Dr. Dharma said. But if it is a MUD or a haplo, which we are not doing for thalassemia right now, it would be prudent to do it much more frequently. We've not had great challenges except in a couple of patients where we had GI gut symptoms, and there was one patient who had CMV positive as well as had GVHD-like phenomena. So it was a big challenge how to balance the immunosuppression versus the treatment for CMV. But we managed with ganciclovir and put him on valaganciclovir afterwards, and he did well. He came out of it, and he's doing very well now. He's 2 years post BMT.
Right.
So it's not been a major challenge because we are focusing more on match sibling donors. Yeah.
Fair enough, man. Thanks. Kashi, I can see you still have your COVID beard. It's not gone yet. How are you? And just to touch with you on BK virus challenges that you have in terms of managing BK virus in Madurai. Your voice, you're muted. Somebody will have to unmute.
Am I audible,
okay.
sir?
Yeah, right now you're audible. You are muted so long. Okay.
So BK virus, we manage symptomatically with hydration and analgesics. We try to reduce the immunosuppression. And then even though Cidofovir doesn't work, we tend to give Cidofovir for these patients. And mainly supportive care is what we do, sir.
Yeah.
It's not only in haplotransplant we face this Cidofovir. We have it in unrelated donor transplant very rarely also.
Okay. Okay. So there was a question actually in the chat box, Francisco, and I think you'll agree with the statement. Practically, BK virus is supportive. All the drugs that we have, really nothing works. Probably the only thing that works is the viral CTLs, which many of us may not have access to at this point in time. Is that a fair statement to make?
Even the CTLs, we don't know, right? There's this data from the Baylor group, but they use a funny definition of refractory, and then, the median time to improvement was 6 weeks. Okay. And we know that these patients take, 4 to 6 weeks to get better. So we don't even know. And the problem is that we have a big gap in terms of understanding the natural history of the disease, right? So we got to do our homework about the natural history.
Yeah.
And I will encourage some of you guys to work on that, like especially the malablative haplos.
Yeah. Francisco, most of us try to cut the immunosuppression.
But if you think about it, we don't even understand, what makes a patient asymptomatic versus symptomatic, right? They have very high virus loads in the urine and in the blood, and some people just live with it for a couple of months, it goes away, and they never got sick from it. And other people are writhing in pain or bleeding.
Yeah.
What's the difference?
Right.
We don't understand that yet. We don't even, right? So things are obvious to us.
Yeah.
Right? It's an interesting thing because we went from not understanding what was going on to virus load, and we skipped the anatomic pathology and the physiopathology and the immunology of this. So very little knowledge. We need to really invest on this because it's a common problem. It is a common problem. I'm not saying there is not a problem. It's just that, we're like CMV in the 70s. We need to study it in the 80s and start, making steady progress. Yeah.
Sure. Dharma, you are asking something.
I was asking, since we don't have other than ganciclovir, till this now Cidofovir will be available, or we have through gay market the Cidofovir. So once those who are copies 1.5 logs is going up, or 2 logs going on ganciclovir.
You're talking about CMV, Dharma, or you're talking about CMV?
I'm talking about CMV.
Okay. Back to CMV. Okay.
So is there any data? We have not experienced to combine Cidofovir and ganciclovir if one drug is not working.
Well, if you think about it, they tend to bind in the same place. So the UL.
Don't know. I don't know.
Yeah. So basically, if you have combining them proactively to see if there is synergy, there is no synergy.
Okay.
Okay. And then if you're suspecting resistance, adding it on doesn't really help. And you really need, depending on the mutation on the virus, if it's a UL97, Cidofovir will work. But if it's at the binding site in the polymerase, a UL54 mutation, it may be resistant to both. So in that day 21, when the virus is not coming down and you do an empirical switch to foscarnet, we get a genotype at that moment. Okay. So in a week or so, sometimes, even those people who went up or more than a log, they're going to have a susceptible virus, right? And then you can scale back down. You don't have to commit them to a longer term foscarnet. So that genotype is worth the cost.
Worth the cost. Okay, got it.
Vikram sir, can I ask one more thing?
Please go ahead.
With regard to BK viral hemorrhagic cystitis,
okay.
Professor Francisco, what do you monitor? Whether it is blood BK viral load or urine BK viral, because urinary BK viral load is always going to be high even after recovery. So,
well, we're not monitoring anybody because it's a high noise to signal ratio and we have no treatment, right? So in the natural history study, we're checking for the virus, weekly for the first month and then monthly afterwards, unless they have symptoms. Or we examine them for other reasons, but it's mostly to make a diagnosis, right? So if somebody has dysuria or hemorrhagic cystitis, we look for BK, but we also look for adenovirus. So even though adenovirus is less frequent, it's much more aggressive, and Cidofovir will work in that setting, right? And these are people who are going to be very brisk, very quick. They get sick very fast. So for those patients with adenovirus hemorrhagic cystitis, and we see a few cases a year, Cidofovir will work and help them out. And then basically it's a syndromatic approach, right? You have this hemorrhagic cystitis and you say, is this adeno or BK, right? Or even for symptomatic cystitis, they say, well, this patient is in a lot of pain or a lot of frequency, right? Remember that both adenovirus and BK, they like the whole of the urothelium, right? So you can have hemorrhagic urethral disease, right? Or inflammation in the urethra, people coming with obstruction, right? Or they have pain on urination. They have urethritis, right? They don't have cystitis, right? So because sometimes in several cases, especially in men, they say, what hurts? It hurts is the penis when they pee, and it's not the bladder. So just to remember, of course, people talk about nephritis, and that's rare in the bone marrow transplant population, but urethritis leading to bleeding and blockage of the urethra and acute renal failure in that setting we see maybe once a year, then urethral disease is also possible.
Okay. So I think one of the questions, Francisco, that Ganesh was trying to address was, would you monitor urine BK or would you insist on blood BK? Say you knew it was BK hemorrhagic cystitis.
Yeah. So, we usually send both once you have a diagnosis to stage people, because if you have a high urine load and a negative blood load, means that the burden of the disease is low.
Okay.
It helps you prognosticate a little bit. Okay. Although the opposite is not true. You can have people with high virus loads in the urine and the blood and be asymptomatic.
Okay. So we don't have a real defined strategy as such. So I'm just going to go. We are running a little bit short on time. I'm going to go to Neeraj. Neeraj, is Neeraj there?
Yes, sir.
Hey, Neeraj. Hi, how are you? Okay, so Neeraj, there's a lot of morbidity with BK virus, and all of us struggle with patients where we have this. Every day you do rounds, the guys in severe distress. How do you manage symptomatology in your BK virus hemorrhagic cystitis?
Yes. So as you rightly said, it's often a nightmare to manage the hemorrhagic cystitis and other symptomatology with BK virus. So a lot of good hydration, analgesia, and we often have to take, and basically it's this is often very painful, and so we often have to give opioids, etc., for the pain control. And sometimes most often we take the help of a urologist, surgical specialist too, because there are clots inside the bladder, and that often may have to be irrigated. So bladder irrigation is a continuous bladder irrigation is one of the things that we may have to do, and till and this may have to be continued for days and sometimes weeks together. More intensive surgical procedure we haven't done, but I know some you lay open the bladder in very severe cases. Yeah.
Okay, thanks. I think we have 5 minutes more. I'm just going to open it out to all the panelists, and we have Francisco with us. Very grateful again, Francisco, for sparing your time. So we can use this opportunity to ask questions directly of challenges that you meet, and I'm sure that will be an educational exercise for all the people listening on the platform. Let's start with Dr. Mamta Manglani.
Yeah.
Go ahead,
so thank you, Vikram. So my question I actually put on the chat also. Do you modulate the immunosuppression in a patient if the CMV does not get better after 2 to 3 weeks?
Yeah. So again, you don't do it in isolation, right? So a lot of these patients do have GVHD, so the oncologists and the BMT doctors will try to lower the immunosuppression. You descale faster if you can, right? So sometimes you can, and that's part of the tricky part, right? So if you can reduce immunosuppression, we do. Especially we try to get rid of mycophenolate and the prednisone. I think those are the major offenders. You can keep tacrolimus, sirolimus seems to be helpful. And then the other thing that we've noticed and we published about dasatinib for when they're using it for maintenance therapy in ALL patients, we've seen CMV events in people who shouldn't have, like people who are 6 months out, no GVHD, and suddenly they come with CMV, and it's people who are on dasatinib. Yeah, but the general study is yes, decreased according to the overall situation of the patient, and we do tend to go faster.
Okay, thanks.
Thank you.
Anybody else? Just one question, because everybody's asking this, Francisco. There's a lot of use of artesunate in India for CMV. There's a lot of questions on the chat box. What's your thoughts on artesunate and CMV?
I haven't used it. And again, I haven't had a need for it. I guess the question would be, you guys are in a position to do a randomized trial and answer the question.
Okay. Okay. So,
Vikram,
any more questions? Yeah, please go ahead, Sharath. Please go ahead. Please go ahead.
Professor Marty. Yeah. So I was just wanting to ask on the adenovirus infection. Sometimes we see it as a very bad hepatitis manifesting, or sometimes even associated with hepatitis. And you told us about using the viral titer of 10,000 or 100,000. So we've seen that initially when we do treat with Cidofovir, it comes down and sometimes it's negative, but there is persistent ongoing hepatitis in spite of that. So what's the plan to either taper off, or how do you come down or continue treatment once you started this?
So you're saying that you have access to PCR, to quantitative PCR?
Yes.
Okay, and then it becomes negative.
Yes.
Yeah. So again, depends on what the situation was. usually we continue treatment even when the titer is negative for a few more weeks. When you have ongoing hepatitis, again, you have to think about GVHD. Sometimes we end up doing biopsies, right? Because it's hard to assess why somebody has ongoing hepatitis. So, but I would say if the adenovirus is down to negative and you still have hepatitis, then there's something else that's causing the hepatitis, okay? On the other hand, we continue for several more weeks after the syndrome, the pneumonia, or the hemorrhagic cystitis, or the diarrhea, or the hepatitis, improve, because we do see rebounds if we stop early. Sometimes you have to stop early because of renal dysfunction, but we continue monitoring because there's a risk of relapse. But the short answer is, if you're still seeing ongoing or worsening hepatitis with a negative virus load for adeno, you got to look for something else.
Vikram sir, can I just quickly comment?
Please go ahead. Please go ahead, Ganesh.
So Dr. Francisco has brought out a very important point. So basically, like he said, for BK virus hemorrhagic cystitis or various respiratory symptoms, you send specific viral test. But many times we see these viral infections are multiple, like not just single virus, but it is multi-viral infections, be it BK hemorrhagic cystitis or viral respiratory infections. So this very important point I learned from my ID specialist, who is quite proactive and a huge help in our practice. So many a times when one particular virus is not explaining rapid progressive downhill course for that particular patient, if you send multiple viruses and then a couple of them are positive, the one which has a worst implications, so you target with available therapeutic agents. So like BK virus hemorrhagic cystitis, patient rapidly progressing and not responding to supportive care, and if adeno is positive, you add Cidofovir. Couple of patients it has happened. Apart from hemorrhagic cystitis, also respiratory pathogens. So that's a very important point Dr. Francisco has made in his previous comment. Thank you.
I mean, adenovirus is a nasty enemy. So basically, anybody with severe pneumonia, especially one thing that's interesting about adenovirus pneumonia tends to be focal. It's not like the diffuse. That's the CMV or right. So it can be very focal. Like a lobar pneumonia, people will swear is bacterial.
Okay.
And then, so any respiratory illness, any GI illness, anybody with bad diarrhea that you're suspecting GVHD, or people that you're treating for GVHD, they were getting better and they go worse. We always check for adeno in that situation. And then hemorrhagic cystitis.
That's a good point. Yeah.
And hepatitis also, so the hepatitis from adeno tends to be very fulminant in the few cases that we've seen. So it's, I don't know, in cricket you have this term that you swing, but it's too fast. It can be too fast. So.
Okay, I'm going to have to stop it here. Thank you so much, Dr. Francisco. Thank you so much again for coming on at such a short notice. I want to thank all the panelists. It was a great discussion. And I'm going to hand it back to Dr.